Ses. Ah.
Tamam da açık mı, çalışıyor mu?
Demin ses geldi ya.
Bakayım mı?
Ses de. Ben kullanırlar. Ama sanmıyorum. Şimdi numara yok ki bende.
Ara sen söyle.
534.
Yemek yiyeceğim, arıyoruz. Arayacağım seni. Hadi bak.
534.
0534
050.
050.
70.
Tamam, çaldırdım abi.
Çaldı, tamamdır. Mikrofonun vereyim.
Tamam.
Ses denemesi istersen. Ses.
Bu açık değil mi? Ses. Yayının sesi geliyor mu abi? Evet. Pazartesi, salı, çarşamba, perşembe, cuma, cumartesi, pazar. Tamam abi, bence gayet yeterli yani siz seviyorsun.
Hoca konuşacak.
Şu an iki mikrofon da açık mı? Şu an iki mikrofon da açık mı?
Öyle olmaz tabii ya.
Abi şu an iki mikrofon açık mı? Abi kapatalım bir tanesi. Abi onu sadece son 15 dakika kullanacağız ya. Olur da bir tanesi şarjı mağazı biterse yayında sıkıntı yaşamayalım.
Tamam, lütfen. Buraya takalım şarjı. Kalsın.
Allah bunu da takalım. Pointer çıkartalım abi sen şimdi. Pointer çıkartma.
Pointer lazım olur mu?
Hayır şu anda çıkartalım. Şarj olurken. Zaten yani konuşma anında şarj edemeyeceğiz. Nasıl kapanıyor böyle mi?
Kapatmasak mı? Demin çünkü şey oldu, kapatınca şey oldu.
Şu an kapalı mı açık?
Alttaki cihazını kapanıyor o yüzden.
Şu an kapalı mı açık mı?
Kablo çek. Kapalı. Demin kapattık ki alttan kapandı. O yüzden Rıdvan aradım. Biraz kapansın diye. Bir daha bakalım şunun sesine. Ses. 1-2.
Bundan alıyor olabilir mi?
Ses 1-2 ses.
Yok.
Ses.
Tamam, geliyor.
Hocamız nerede? Millette kıtacak hocamız nerede? Burada yakınlarda mı? Kıtacak hocamız vardı ya. Bekle almamız lazım. Yoksa.
Abi ne oldu abi? 5 dakikaya getiriyoruz. Zübeyir Hoca ile hava almaya mı çıkmışlar? Ha. Oradan getireceğiz. Aynen. YouTube kısmında bir şey oldu mu? Ha, deneme mi açıyorsun? Ha, genel açık yaptınız. Tamam. Ha, buradan devam edeceğiz. Kapatıp geri açarız da. Kapatıp geri açsak olur. Ses denemesi yaptınız mı? Yapayım mı? Yaptınız. Ha, tamam.
Ama bir gecikme geliyor. Bakın ses.
Zaten YouTube 15 saniye gecikmeli veriyor.
Şu an 8 saniye gecikme var yani.
8 saniye değil mi? Evet. Gayet iyi. Bunun bize bir manisi var mı? Tabii. YouTube'a zaten geçiyor. Mikrofon şu mu?
İşte.
Ses 1-2, ses.
Orada görüntü izleniyor. Oradan alacağım ben şu an gözüksün diye.
Ben şu birazdan mektubu getiriyorum. Hocam videoları çekiyorum.
Şu an tek bir sık mektupla gözümün hesabı.
Tamam. Aslında çok güzel. Sonra video atmayacak. Bir daha geleyim ses. Ha tamam. O ses güzel. Ses güzel olduktan sonra
Hiç mi diyorsun? YouTube'u hiç mi diyorsun? Tam başlangıçta başlasın da öncesinde boşuna olmasın diye.
Evet. Yani burada geldik. Hoş geldin. Şöyle hiç uğraşmayabiliriz. Ben sonradan keserim. YouTube'un kendi içinde edit var.
Yani kesersen tercihin olsun. Benim şimdi
Tamam. Şu an çok erken başladık diye.
Çok sıkıntı. Yani şimdi
Tamam.
kapatırız. Açarken tekrar sıkıntı olacak. Sonra başımız
Tamam
ağrımış.
abi,
O yüzden
sorun
yani.
değil. Şu an YouTube yayında diyorsun. Hiç başımızı ağrıtmayalım. Zaten biraz geçeceğiz gibi. Ben hızlıca bir
Tamam. Tamam. Bak burada zoom da açık. Bakacak mısın?
Şu an sen de hoş geldiniz.
Merhaba canım.
Merhabalar. Merhaba. Hocam aynı anda YouTube'a vereceğiz. Canlı yayın. Uzaktan olan arkadaşlar izleyebilsinler diye. Yani sizin cihazınızı Zoom'a bağlayıp sunumunuzu o şekilde vermek istiyoruz. Çünkü Zoom'dan direkt YouTube'a canlı yayın açabiliyoruz.
Geçen başka bir üniversiteye de davetliydim. Aynı şeyi yapmaya çalıştılar. Ben ne zaman full ekran yapsam Zoom'dan koptu. Haberin olsun. Zoom'a aynı şekilde bağladılar. Ne zaman ben tam ekran yaptığım şeyi Zoom'un kapandı falan dediler yani.
Sizin deneyelim hocam.
Tamam.
Zoom
sen
vardır herhalde
kullanırsın.
sizde. Tamam. Kısa
Pointi var.
böyle bir şey çekmek istedim. Böyle birkaç soru soracağız. İsterseniz şimdi yapabiliriz ya da sunumdan sonra yapalım.
Şuna bir önce 2 dakika bir dinlendirip sunayım.
O zaman 5 dakika falan zaten başladı ama istiyorsanız çıkışta sizi birazcık daha yormuş oluruz. Bir videoda çıkışta atlayalım.
Hocam suyu oğlum. Gelsin.
İlk kullanmayı biliyorum.
Ne abi biliyorum.
Zoom açalım. Sen yapsana. Sabun var mı? Gmail. Google.
Ben kendi şeyimi vereyim.
Sen söylüyor musun?
Ama performans kötü seviyelerinde ama.
Misafirin bakmaz.
İşte aynı mı? Bak ben kendi şeyimi verebilirim.
Kaç tane belki yapalım? Kaç tane diyor sana?
Sen tansiyonu alır mısın abi? Evet. Tansiyonun iddiasını konuşar mısın?
Bayağı kalabalık bir araya
Evet.
geldim.
Kullanıcı adı?
Caner.erkan@medipol.tr.
Bize gerek yok.
Şifre.
Z büyük Eyna
Eyna.
1453.
Sağlam bir şey istiyor.
Parmak istiyorsun.
Ha.
Ara rıtmanı bir daha. Bağlanmadı mı?
Hocanın parmaklısı lazım. Hocanın laptopu ya.
Sunumu aç.
Bu ne yazıyor?
Hatırlamıyorum belki diyor. Tahmin et çalıştı falan.
Abi gelsene. Sen yazsana.
Tamam sen o zaman
Bana mı diyorsun?
Aynen.
şu an sen misafir et.
Yok tansiyonu bağlamış.
Tamam.
Şey,
Ete yakın.
et gerekmiyor mu?
Yok abi.
O zaman Caner Erkan yazın nokta.
Abi aşağıya.
Senin mailin var.
Evet. Ne diyor?
Niye olmuyor?
Devam edeyim mi? Tamam, böyle bir şey geldi.
Şey misafir et.
Pardon, buradan gitmeyeceğiz. Nereden?
Tekrar bir bakalım. Misafire bağlı ikisi.
Onu iptal edeceğiz. Oraya ben TC kimliğimi yazayım. Caner Erkan'ı yazmayayım ya.
Ben mobilini paylaşsam çok kopar mı acaba?
Neyse, hattın ne Tufan'da? Vodafone kopar.
Ya zaten çarp çevirdim.
Aa bir şey söyleyeceğim. Ethernet çıkışı alamaz mıyız buradan?
Var mı ki?
Oradaki İstanbul olmaz.
Ne?
Ne?
Abi hoca dönüştürücü var.
Bir tane. Bir tane koptu.
Nasıl açılıyordu?
Alttan bir
Ama
tane
şey,
şey var.
bence kaçmayı daha fazla kablo yok.
Yok mu?
Alttakine mi basmak? Yap. İptal mi etmek istiyorsun? Şöyle TC'mi yaz.
Ben yazayım bak. Mesela kaç film diyor.
Mikrofonu ben kendim götürebilirim. Wi-Fi paylaşayım mı? Bunu bağlayalım.
Ben Faruk.
Aynen.
Ben Faruk. Bu direkt misafir yapmak misafir çıkıyor. Ben işte boş boş.
Ne oldu abi misafirden mi?
Bir şey söyleyeceğim.
Direkt Ömer'in
Abi zaten yine hocanın dönüştürücüsü kullanmamız lazım.
Niçin?
Kanka pointer'e bağlayacağız ya.
Ben sağ sayfam desem. Bence bunu yapma ya.
Oradan mı? Oradandır. Google'dan Google'dan uğraşmayın. Mesela
Abi bir şey söyleyeceğim. Yine Touch ID isteyebilirim.
Bekleriz. Bekleriz. Bakın sayfamızı bekleriz. Hocanın bahsettiği problem nerede?
Geliyor.
Zoom'da oturuyor.
Gideceğiz abi. Ama bence Mahmut okuyacağını
geldi
sanmıyorum.
hocam.
Esin aparat var mı hocam? Hocam kullanmaz. Uyarlarsa herhalde uyarlar.
Genelde kullanım yok. Herkes çok yok. Yani orada ben nasıl soracağım?
Hocam sularınız burada.
Sağ olun.
Kalem.
Zaten çok anlamadılar.
Başka bir soru ben bir tanıtayım. Ben önden şey hocam tanıtacağım. Siz hocam arkadaşlar.
No, no, you're fine. Pointer çalışıyor. Çalışacak.
Aslında YouTube için. Partiyle alakalı. İndir.
Evet, boş ver. Burada video var. Tamam. Thank you very much. Thank you very much. Before I start, I would like to thank my dear friend Zubair. He's not only a great faculty, but also a great person. So it's a great pleasure for me to be with him first, but it's a really pleasure for me to be with you. And I'm very happy to be here. First of all, what I'm going to talk with you today, I'm going to just introduce myself, and then I'm going to talk about a little bit a brief story of myself. And I'm also going to give you an overview about the neurosurgery, because it's important to understand some concepts about neurosurgery, and there are some subspecialties about that and of the neurosurgery. And then I'm going to talk more details about the cerebrovascular surgery, which is my field. And then we are going to talk a career in United States, you know, how, what are the difficulties, what are the expectations from you, this kind of, and then we will talk with a question and answers part. I would like to answer your questions. Basically, I was in Istanbul University with Zubair for many years over there. We graduated over there, but after that I went to residency in Izmir Tepecik Training Hospital. After finishing my residency, I went to an obligatory service to Gümüşhane, which is 2 years. I was almost 1.5 years. I was the only neurosurgeon in that small town, and I worked there about 2 years. And after that, I went to University of Wisconsin. I started there as a research associate, and then had lots of titles over there, you know, research specialist, then became scientist, lab manager, and I worked there a lot. I had a great opportunity to meet with great people over there. Basically, that's one slide that I prepped for introducing the laboratory to the other hospitals while I was working there. I'm sure they have done many more studies after I left. There were many fellows, international fellows over there. We published lots of papers, lots of abstracts, some courses. We had great experience over there. Dr. Bashkaya, Dr. Dempsey, you can see. And then that opportunity gave me to work with other surgeons. I was invited as a faculty to many other micro neurosurgery courses, some neuroanatomy courses. I went there, give some lectures. These are some of them in Chicago. And then I had the chance to go to Yale, and first as a scientist, but after that I went to cerebrovascular and clinical fellowship over there. And then I ended up in Harvard. But everything started step by step. So basically, when I went to Wisconsin, I had no experience. Not no, but just a very limited experience on neuroanatomy and the neuroscience, and also I had very bad English, and then it was very hard for me to give some talks. So I started to work with the undergrads, and then after I give some lectures to them, I started to feel comfortable after many of them. And then I started to work with medical students. Then after that, neurosurgery residents. And then I started to give some lectures to the really big names in neurosurgery field. But it's step by step, it comes in time. And that's some of the other courses that we done over there. And I felt much comfortable, but these kinds of things go step by step. I would like you to evaluate yourself and then find your weaknesses and then make your weaknesses your strength. And sometimes your strength can be your weaknesses, and sometimes your weaknesses can be your strengths. And if you study your weaknesses enough, it's going to be a strength for you in time. But if you think that I'm very good at that part, and if you think you're the greatest, after 1 year, you are not going to be the same position. After 2 years, you're not going to be the best. So it's your strength became your weaknesses. But if you study hard, your weaknesses can be your strength. So if you find that, it's going to be very important step for your career. So we have done some studies over there, and I think that's the only one. You can see over there too. I don't want to stand over that you can see. But basically, I'm going to talk about some of them. And I'm going to talk about neurosurgery. Neurosurgery is a field that you can do many kinds of surgeries, not only the brain, but also the spine, also the peripheral nerves, and entrapment problems can be solved by all neurosurgeons. And these are the World Federation's subspecialties of the neurosurgery. It can be, you can be a neurosurgeon which do only spine surgery, and can be the lumbar disc herniations or the some trauma, some fractures of this, the vertebral bones. You can do a spine surgery, or some neurosurgeons do only peripheral nerves, brachial plexus and then the nerve entrapments. You can be a vascular neurosurgeon like me, but there are two ways to do that nowadays. You can do an endovascular, or you can do an open and operative, vascular neurosurgery, which we do regular craniotomies and then do the treatment with a regular surgery. But also you can use some arteries to reach that pathologies to fix them. I preferred to learn both ways. So I think that's important to use your knowledge, not to choose the best way for yourself. If you know both ways, you can choose the best for the patient. So sometimes if you know only the open surgery, you think that open surgery is great and then you recommend that. But if you know endovascular only, you are going to do the same thing for the endovascular. But if you know the best, both of them is necessary, because you will find the best way for the patient. So if you can do tumor surgeries or neuro-oncology for the as a neurosurgeon, as a carrier, so you can do neuroendocrinology, you can do pituitary surgeries, and then all the endocrinologic problems that can be solved with neurosurgery. That's another subspecialty. You can do skull-based neurosurgery. What we why we do skull base as a subspecialty, because taking out a tumor or doing a surgery just superficial of the brain, it's not going to be that hard. So you just open a small hole over here, and if the pathology is over there, it's easy to take it out. But when there is a problem in the base of the brain, we call skull base, it's hard to manage these kinds of things. So you need to train that. So it's called a skull base neurosurgery. You can do only pediatric surgeries. And there's also another part of neurosurgery called functional neurosurgery, which you can treat Parkinson's disease, some psychiatric diseases, also some epileptic patients, some seizures. If there is a significant resistance, you can do some surgeries with that. Also, some neurosurgeons doesn't do any surgery. They prefer to work with the patients in the neurocritical area, and then you can do only neurocritical care. That's also possible. As I would like to show you that slide, because neurosurgery has many options. And if you become a neurosurgeon, it's not going to be the sleepless nights all the time. You know, there are some of them is much easier. Some of them you can do emergency cases all the time. Some of them, some elective cases, and then you can go home and sleep more comfortably. Spine fractures, and then you can do all these and this spinal neurosurgery. And then this patient that while I was in Yale, it's a deep brain stimulation patient. While I was there, when I have some separate times and availability, I went to do other rooms, and then I work with the other faculties over there to do these kinds of surgeries. That's not my specialty, but it was a great case. It's a Lennox-Gastaut syndrome, which is a resistant. The patient had a seizure problem, and then 4 or 5 different anti-epileptic seizure medication didn't work, and then he ended up in deep brain stimulation. In this, we have a small hole, and then we put an electrode to the central medial nucleus of thalamus to give some stimulation, which is going to the location can be decided with an MRI, and then these tools we connect that to the skull, and then with these probes we can find the real trajectories, and then we put the patient into the MRI after we put all this stuff, and then in the MRI as a millimetric measurements, we need to find the exact same location, and we can find the trajectory, and then if on the right, left, up and down, we can arrange all these by using these tools. And after that, we connect that to some batteries, and that's going to give some electrical stimulations over there, and then it helps a lot for these kinds of patients. These are the some samples for the other subspecialties of the neurosurgery, but the cerebrovascular surgery, as I mentioned, you can do as a microneurosurgery and open surgery. I'm going to give you some examples, but the thing is, you can do as an OR in the OR like that, or in the neuro IR suite, by using some X-rays and do an endovascularly. In order to do an open surgery, you need to know anatomy very well, and you need to study in the lab. Like every step, you need to work with the microscope, but it's a different thing that you do every day. Or your brain is not ready to look to another direction and then do something in another direction. So when you look at the microscope, you look that way, but your hands over here, you need to prep yourself to do this. And also you need to use very fine tools in a very small area. So you need to spend lots of hours in the neuroanatomy laboratory, and then microsurgery you need to work. So that's one of the patients that we published with Dr. Bashkaya as one of his cases. He's my mentor and is a great surgeon. I would like to show you that over here. You can see an aneurysm over here. You see over here, that's a middle cerebral artery, and then there is an aneurysm. You know what is an aneurysm? It's an outpouching of a vessel which can be ruptured and then cause bleeding, and eventually it can cause death or significant morbidity, mortality. What we do under the microscope, we separate the frontal and temporal lobes over here. In this location, we prefer that kinds of approach. And then when we find the arteries and then nerves, which is an optic nerve over here, you can see, and we follow the carotid artery, and then we can see the middle cerebral artery over here. These are the magnified images of the real, during the real surgery. We need to protect the brain, so we use some cottons like that, and then we don't want to damage the brain while we are pulling or pushing it. So there are also lots of vessels around, but there is an aneurysm over here, which we need to remove the flow into that artery. And then we can see all the other arteries. I don't need to give you that much details of which arteries over there, but basically we need to protect some of the arteries. We need to stop blood flow into that aneurysm. So while we are doing that, the very gentle moves we need to do, and we need to separate the brain from that arteries. Here we use a temporary clip to stop the blood flow to whole area, to whole artery. And when we put that, you need to be very quick, because the brain, some part of the brain get no blood flow after we put that. But it's going to also decrease the pressure. So it gives us that we can remove that connections at with the aneurysm and the other vessels. We need to dissect them out. If you don't do that, sometimes it gets ruptured. Do you see that little bubble? It's a very ugly looking aneurysm. From that small bulbs, it can get ruptured very easily. Now you can see an aneurysm clip. It's closed the blood flow to the artery, the aneurysm, but the artery is filling very well, and then we can see the whole ventricular striate arteries, the other branches, the perforators, and then we check not only with our eyes, but also there is a intraoperative angiogram which shows the flow of that arteries. So after that, we remove the temporary clip out, and then we left that permanent clip on the aneurysm, which is going to, you see the aneurysm is gone, and the whole anterior cerebral, middle cerebral artery is feeling very well. So that is the microneurosurgery. And then in order to do that, we need to study anatomy very well. We need to be very fluent and then very comfortable with all the approaches. So we use some cadaveric heads to understand the anatomy better, that's a very long videos. I'm just keep it short. And then in step by step, we need to practice every step in the laboratory that we can be fluent and then comfortable enough to know the anatomy and also do all the necessary moves for the real surgery. We practice over here, and then we can do. While I was as a resident, I was very lucky enough to talk with Dr. Gazi Yaşargil, and it was a great moment for me. He said that, soccer players, they are practicing 1 or 2 times every day, almost every weekday. And then they play soccer. And we are doing surgeries in the brain, and we are not practicing. Do you think it's something logical? Definitely, you know, we need to keep practicing, and then we need to keep our skills intact. And you can do laboratory studies, and then everything is going to help you a lot. So in this study, I give different dyes into different arteries. For example, I give white dye to the posterior communicating artery, and then you can see whole perforators comes out from the PCOM. And the red one is the anterior choroidal, that's the ICA. And then that's the posterior circulation. You can see the basilar, and then PCA is over here, posterior cerebral artery is over here, and then SCA is over there. And what is that white dot? These are nerves, right? That's the cranial nerves, oculomotor over here. What is that white dot? Anybody? That's Burger King, or McDonald's, or too much fat, right? It accumulates in our vessels. So that's what it is. You can study anatomy, and also while you are doing that injections, also you use all the tools that we use in the OR. So you practice all these too. It does help you not only understand the anatomy and then publish some papers, but also it enhances your skills on microsurgery. Also, we use some small vessels to practice. You need to practice. You see, that's a terrible one. You need to do practice and pray. You can start like this, but if you practice enough, you can be like that. That blood flow, it's not going anywhere, but this one goes right away. So you can see the difference. This one, when you cut that, it's going to be terrible like that. But if you do a good job, all that sutures comes perfect, and then you have a great lumen over here that flow pass through it. So we can connect the brain vessels with each other, or we can take one of the vessel and then connect to another part of the brain. We call bypass surgeries. So if you need to practice to do this, there are many things to practice over here. Some people use animals, other ones. I give some lectures about that, but I'm not going to give you details. But even at your home, you can practice if you want to be a good surgeon. That is one of the most commonly used ones. You can use some silastic tubings, and then under the microscope or some loops, you can practice suturing one by one, like that. So these are all two-dimensional. Actually, you do these kinds of suturing on the table. That's good. But if you do good enough, you need to make it like more realistic. So in order to do that, I come up with an idea that we can combine that, and then we can simulate whole steps of the real bypass surgeries, and basically regular simulators that you can use to practice about $15,000 or $20,000. But I've just come up with a $300 a very cheap one, but it's a very realistic one. We published it in Journal of Neurosurgery. You can see how we prepare, and you can find it in the Journal of Neurosurgery. It's more in detail, but step by step, you prep that. It also has a flow in that artificial vessels. There is a real surgery view over here, and then what we do in the real surgery, including the skin incision, we can do with that bypass model. And then every step we can do. So you can practice even at your home to be a good surgeon. And then when you remove that clips, there is a bleeding in that artificial brain. It's very similar to the anatomy. And then I come up with a better, I think, model because it's cheaper. And then after you finish your microneurosurgery training, you can eat them. It's a grapefruit. The first model was the superficial temporal artery and the middle cerebral artery bypass model. So that part of the brain we can train. But this one, another part of the brain that is an anterior cerebral artery. I'm not going to give you details, but that's almost $15 you can. It's dollars, but how much you pay for a grapefruit over here or 2 chicken wings? This is 15 Turkish liras over here. In the United States, it's $15, but it's very cheap. And when you do that, it's going to be a realistic model because it's going to be the same depth that we need to pass while we are doing the surgery. We measure that in 20 brains and then 20 grapefruits. I had to eat too much grapefruit after I did that study. But the thing is the same depth. And then in the brain, in the interhemispheric fissure that we do the anterior cerebral artery bypass, we need to pass through in between 2 hemispheres of the brain. Now you need to pass through 2 parts of the grapefruit, but you need to be very careful to protect the grapefruit. You have some sutures, you have some very sharp tools, but if you damage the grapefruit, it's going to warn you that you are damaging the brain if you do that in the real surgery. And because a grapefruit juice is going to come out, it's going to be kinds of brain damage or bleeding that is going to give you that idea. So it's how do you prepare. You can find that in World Neurosurgery. It's another thing, but it's very easy to prep. This one. This is a basic science study. We do a 3.5 grams pups of the mice. The whole animal is 3.5 grams. We worked in the ischemic encephalopathic studies, basic science studies. But while doing that, in the carotid arteries of that animals, I've done hundreds of them. And by using that microneurosurgery tools, not only I publish some papers and then do some make money from that studies, but also I enhanced my skills in microneurosurgery. So while you are throwing a stone, you can hit more than 2 birds. So you need to think, and then while you are studying, it can help you not only just publish papers, but also it can enhance your skills. We published some big, good papers in Wisconsin. And then I talk about microneurosurgery, the other fields, but endovascular neurosurgery is another part of the cerebrovascular surgery. It's basically when we have a problem in the brain, we can use an artery. Most of the time we were using the femoral artery to access the arteries, and then we, by using a catheter, we go up and reach to the brain vessels, and then by using different kinds of catheters, we can even reach inside an aneurysm that I showed you the microsurgical treatment. We were outside the vessel and then we put the clip, but this one inside the vessel, we go inside, put some coils, come out, and then we can stop blood flow into that aneurysm. That's another way to do it. And AVMs, these are the arteriovenous malformations, and that's abnormal connections between an artery and the vein, and that increases the pressure inside the vein, so that causes bleeding and mortality, high mortality and morbidity of a patient. And in order to prevent that bleeding, we have many things to do. For example, we can go inside an artery, goes to artery which supplies this area, and then give some glues or put some coils, whatever, stop the blood flow to that area, and then it can help. Also, sometimes it's small or low risk. We just observe them. I'm just giving you that part because you don't think everything we do the surgery or something. Or we give some radiations to that area that shrink the vessels and fix it. Or also we can do the surgeries, open surgeries to stop the blood flow over there and take that part out. And if you know different techniques, you have some different tools or different guns against an evil disease, okay? And there is a fight in between open surgery and endovascular nowadays because it's a huge field. And if you know both, there is no fight. And then, as you see, nowadays, we not only put some coils, but also some stents. Also that stents, different kinds of stents. Some of them we can use to help us for the coiling. Some of them we can just leave the stent, and then that stent is a flow diverting stent, which changes the flow of that blood flow. It doesn't go into the aneurysm or that problem, and it's going to fix the patient. So we use some balloons, different kinds of things. But there's also another study we done in the Wisconsin laboratories. It was in Newman lab. It's a rat. That's a tail of a rat. And as you see, I just dissect a tail artery of the rat. And it's not only a study, but also it's a practice, right? We practice the dissection of the vessel as a microsurgery, but now I put inside that small artery and small catheter, and then I go up, starting from the tail, I go to the brain from here. It's a good study. Not only we practice the neurosurgery, also we practice the endovascular surgery, right? So I'm pushing here, I'm going through that, past that aorta, and then you can see that's the heart of the animal. And then I give a dye, and then you can see the carotid arteries. I find them under the X-ray. We select the common carotid and goes to the internal carotid. Even with that, we can go into that middle cerebral artery, and we can do middle cerebral artery occlusion with that. And then there's temporarily we can remove the catheter after 1 hour, and then we can cause a stroke over there. Ischemic reperfusion injury can be also done with this way. But if you know the both techniques, sometimes one is not enough. So with this patient, was one of the patients, Dr. Ogilvy, that we have done in Harvard. It's a huge arteriovenous malformation. It's a big animal over there. So we need to fight very hard. As you see, it's a huge, almost frontal lobe, almost whole frontal lobe. Oh, okay. You see, we use some glues to stop blood flow, endovascular techniques. After many, it's going back, it's something wrong over there. Anyway, after that, after using some glues and endovascular technique, we remove that tumor with an open surgery. So they are not enemies. They can help each other. So it should be the enemy of the disease, not the doctors. So there is another great thing that we can do nowadays. If there's a blood clot, stops the blood flow of the brain, we can reach that clot with a catheter, and then by using some stents or without them, we can remove that clot from the brain. So the strokes can be treated by this way. So that stent opens inside that clot, and then it holds that clot. And also they say that while that's expanding, it starts to create some blood flow distally. I don't think it's too much effective over there, but the thing is, it holds that clot, and when we remove that, the clot comes out from the leg This is a balloon that temporarily stops the blood flow over there to protect the distal embolizations. But anyway, when we remove that clot, the blood flow goes to the brain, and then the patient can be treated by this way. Another technique that I love, it's very fast. You don't need to open the stent or something. The same thing. There is a problem, occlusion in the brain. We go inside in this one, it goes from the femoral artery, but I prefer to go from the radial most of the time. It's less invasive over there. Then you go into the artery, you can go up, and then you can remove the clot by just sucking it out. It's actually, that's one of the fastest techniques in Yale. We had the patient in 4 minutes. We finished the surgery in 4 minutes. So as you see, we take it, clot it out, and then you can suck it or you can take it out by this way. Okay, the number needed to treat for thrombolytics in ST elevation MI is 43. You need 43 patients to show the benefits of the thrombolytic medications in ST elevation MI, which is a great treatment. In epinephrine helps 1 of every 7 patients in cardiac arrest. You can think like that. But in that technique, it's almost in 2 patients, and it helps. And the number needed to treat is 2 or 3 in different studies, but that is the great technique. You can see the flow in middle cerebral artery territory is not there, but after that thrombectomy, it's all the branches comes back, and time is very important. And for this, you need to be very quick. That's a great case I've done in Harvard with Dr. Thomas as one of my great mentors. So it's the basilar artery, right? Where are the posterior cerebral arteries? Now that's the lateral projection. The vertebral arteries comes together, basilar here. PCA is not there. Vertebrals comes basilar here, PCA is not there. The patient collapsed while shopping in the grocery store, 53-year-old lady, and patient was walking over there shopping and collapsed. They take it out, take to BIDMC, and then we found that the PCAs are not filling. There is a clot. We take it out, and then you can see whole PCAs over here. You see, while that's moving, the first picture was good, right? You can see better. This one is a little bit blurry because patient started to move, and then after couple minutes, maximum 5 minutes, patient opened her eyes and then asked where I am. I was shopping because the patient was in deep coma, and when we take it out, patient turned back to the life. It's a great feeling. That's the beauty of cerebrovascular surgery. That's another case that we have done over there. We couldn't reach to that area. As you see, the middle cerebral artery is not filling, the anterior cerebral is filling there, but we couldn't reach from the femoral artery. We went through the radial artery, goes here to the brain, and then we take that clot out. As you see, we first find that with the microcatheter. There are too much details that I don't want to show you, but after that, we open that area that's now filling. Endovascular, you can say all neurosurgery, you can feel great. It's a great thing when you remove a clot or when you fix a patient. It's perfect feeling. And then I love that because of these, but sometimes you have some complications. It's not always a happy field. You know, sometimes we have complications, and there is a catheter which is kinked, stuck in the vessel. You feel terrible and then very bad. And then sometimes you can feel when you remove that things and when you fix the brain, you feel like a proud matador and you feel really good. I'm greatest. But if there is a complication, you don't feel like the same. Sometimes you may feel like that. So you need to be ready to both sides of that. So in order to prevent that kinds of feelings, you need to study really hard, okay? So because of that, I showed you some techniques and then some ways to practice. Now, I'm going to go to the next part of the talk. We talk about neurosurgery, cerebrovascular neurosurgery, and then I give you a brief story of myself. In the United States, I can give you a little bit experience over there. The people over there has a different pathways to finish the residency. And if you would like to have a career over there, you need to understand what is the difference. You know, they have different paths after they graduate from, you know, kinds of an university. They pass MCAT exams, and then they go to the medical school, and then they know the system over there very well. And then each parts of that, there are different steps that you need to take. But if you come from abroad, and if you are an international medical graduate, you go to that area from another path. The thing is, you need to pass the steps. I'm sure you know that these parts very well. There was an step 2 CS, now it's changed, and there's another pathway. But the thing is, I would like to mention with that Pepe, if you are a United States graduate, you feel more comfortable in that when you apply for residency. You are happier. And if you are international medical graduate, you know, it's not that easy to get accepted to that area, because, you know, they come from that culture. They know, they pass the same steps, each levels they learned something, and then you are bypassing that and then going to that area from another way. So you miss some of the things that they learned, they got along the way. The recommendation letters, CV, visa, and everything is very important to apply. And then you need to show that you are like one of them. You know, your personality is very important. You know, you need to show that, you know, you need to have good scores from the steps, and you can talk about that stuff. But I would like to give you that idea. You know, being a good person is always counts, you know, everywhere in the world, wherever. If you want to go to the United States, or if you want to go to the Germany, or wherever you want to go. If you are a good person, if you have good clinical knowledge, that's great, professional. But that guys, they also are hiring somebody, they are going to leave more than their families, and then many hours, many days they are going to live together. So you need to also show your personality, and then you are a good easygoing person or a hard worker. You need to show them, and then you need to study more than that people, because, you know, they have many debts in their bank accounts because they came from the regular pathway. You bypass that area, you know, $300,000 or $400,000 they need to pay because they went to medical school over there. Because of that, they would like to hire that guys first, comparing with you. But if you show yourself, you are really good, you are hard worker, you are a very you have a very nice personality, and then they will start to think about yourself. And you need to work harder. And then if they have 2 publications in their resume, you need to put there 5, 6 publications, maybe more than that. If they put 5 posters, you need to put 15, 20 posters over there. But it's not impossible. It's definitely possible. Many people have done this, but you need to work hard. And then, as I showed you in the very first slides, you need to take that step by step. You cannot start running in the first part of your marathon. You know, you have to first have dexterity, and then you have to work hard every day. Then you can show how good you are in that marathon, and then you can show how talented you are. And then I recommend you to show yourself and show your personality and everything while you are working with them. You know, you can do pre-residency programs and then sub-I programs. You need to have a good connection and then good relationship with all residents and over there. Step by step, you need to be patient but consistent. Michelangelo says, if people knew how hard I had to work to gain my mastery, it wouldn't seem so wonderful at all, he says. Einstein says, genius is 1%'s talent, 99% is hard work. You can enhance your skills dramatically by working hard. I would like to show you the very last video here. That is a video that I really like, that my wife showed that. She found in the internet, and then I edit it and then make it shorter for you and then make it a little bit faster. But the thing is, while they are, I think, investigating the mountains or doing some video recordings, they find that 2 bears. And one of them is very small. Likely it's the mother and son or daughter, whatever. The big one is going through a big mountain, and the other one is following. I thought that that is representing my mentors, and then that small bear representing myself. Because, you know, when I started to my career, there was a mountain that I need to pass, that I need to climb up. But I was just a little bear, had no experience, and then I don't know how to go there. So I was following my mentors, and then my mentors was passing through the difficulties very easily with their knowledge and experience like this. They were climbing, but I was like that. But they were telling me, work hard and don't give up. And I was trying going up. And then there was another difficulty. You know, I had many difficulties, many weaknesses, but I was trying to climb. Every day I was trying, doing my best, but it takes a long time. And I was almost there. Nope. It's not that easy. It's not that easy. And this one, you know, you have to pass that USMLEs and stuff. And I passed that USMLEs after 16 years of my graduation. You know, they are taking that exams while they're in medical school. And after 15, 16 years, you don't remember this stuff. And it's not that easy to study basic science that, you know, you're not going to work, you know, you don't use any of them. But taking that steps, you know, doing some mistakes, feeling like this small pup, it was exactly like that. You know, I was climbing up, doing some studies. It was not working. I was failing. I was like that. You know, the only thing you can do, go down. Okay, go down. First, you need to go down. And then some place you need to grab that mountain again, and then you need to climb up again. You need to keep climbing. I'm going up. If you feel weak, if you feel uncomfortable, you need to remember this pop, okay? I know it's not going to be easy to find that power, but remember that small pop that climbed that mountain with just working hard, okay? Along that way, you're not going to be alone. You are going to have great mentors. Great people will be with you. They are going to be your family, and then they are going to be your friends. You're not going to be alone. You are going to find great people. And don't feel hopeless. And if you are not going to be successful, as Atatürk says, you know, there is no hopeless situation. There are hopeless people. I've never lost hope. Never lose your hope. Thank you very much.
Thank you so much for this great presentation. And we will take the questions from you guys. And I will bring microphone for YouTube stream. So if you have questions, you can ask now. All right, start with Sinem.
I wanted, okay, I can't turn down. Yeah, I wanted to ask,
Sure.
what was your triggering purpose after you finished your residency in Turkey to make you go to States?
Yeah, great question. Thank you. You know, as I mentioned, Dr. Yaşargil, Gazi Yaşargil, I met him while I was during my residence, and then he was doing the neurosurgery perfectly, and then it gives me a great hope that, you know, I can. And then he was very humble and then very nice person that give me his time to explain to, if you work hard, you know, you can enhance step by step, one by one, and then you can improve yourself. Going to United States at that time is like throwing a stone and then hitting multiple birds at the same time for me, because, you know, if I can go there, I could improve my English. I could improve my knowledge on neuroanatomy, and then microneurosurgery. Dr. Bashkaya was a great surgeon and still one of the best in the world. I can learn from him. And then, you know, while I was over there, I thought that I can hit multiple stones at the same time. And there are great people over here too. But the thing is, you know, improving English, having an, you know, experience in outside from Turkey, it was like that for me. So because of that, I choose that way. And every day I spent over there, I felt that I was getting better, and then that kept me over there. And then in time, if you work hard, you can fix the problems, and then you can solve the problems that you see. It was not like, you know, you are in a flower garden smelling flowers every day. I'm improving. It's not like that. It was sometimes very hectic. It's sometimes very painful. You know, I didn't show it by, you know, chance to that small pop. I was going down, up and down and down and up and down. That was like that. It's going to be the same for you, I'm sure. The only thing you need to do, you know, if you are doing something good, and if you are aware of that, you need to keep consistently work hard on that. Okay?
Or question.
Sure.
So, like in Turkey, among most of the medical students, do you have a strong belief that for IMGs, it's almost impossible to be a surgeon in the States. So is
No,
that
no, no, no.
correct?
Definitely not. There are many international medical graduates. It's very hard. It's extremely hard. But people can do very hard things. I know. And then you are really smart people. If you all, I just wanted you to motivate, not only to, not only to go out, if you can stay here and then you can be a great surgeon or a great person. You need to work hard, whatever you do, wherever you do. If you want to do a good job, wherever you are, you need to work hard. You need to go like that. Sometimes it's going to be very hard, but the place, it's not the issue. The issue is the difficulties and then yourself. Where do you put? What is your approach to that? You can give up or you can keep working on that. If you keep working wherever you are, you can succeed. It's hard. It's very, very, low possibility, but people told me that it's almost impossible to, go and then have a career over there. I heard that hundreds of times, but you can do.
Okay, thank you.
You're
And
welcome.
thank you also for the presentation.
My pleasure.
And thank you for your presentation, by the way. I want to ask you about your overall job safety, because what I believe is neurosurgery is the most dangerous area that you can work. Is the most susceptible. I'm sorry.
Subspecialty?
I couldn't pronounce. I'm sorry.
Okay. It's
A
hard.
tiny
Dangerous,
mistake can lead to huge injuries. And
Yeah.
I also heard stories about US healthcare system, like the healthcare lawsuits. And I wanted to ask you, how do you preserve yourself from that stress? Or do you feel any stress at all?
Neurosurgery is one of the most difficult parts of whole medical. But, other surgeries also stressful too. But neurosurgery is it's very hard to go back if you have a mistake. Because of that, it's more dangerous. The thing, because of that, you need to practice a lot. You need to know your limits. And if you are a general surgeon or orthopedic surgeon, you need to know your limits. You need to know the safety zones. Then you need to work on that area. And then if you practice hard, even if there's a problem, you can fix it. Everything comes from that. The stressful, yes, it's very stressful. But when you succeed on a very hard surgery, it's joy. It's that big. It's kinds of combination. If you like that feeling, it's going to push you to work on that harder, and then makes you do a better job. But on the other hand, sometimes it's very stressful. You need to find your personality and then what field you feel more comfortable, and then you can choose the best way which is going to fit your lifestyle. I felt that the surgery, first I decided surgery is good for me. Then I decided neurosurgery is nice. Because of that, I wanted to show you the other subspecialties of neurosurgery. That neurosurgery is not the only brain. You can different kinds of lifestyles, even if you are doing neurosurgery. But basically, it's stressful, but on the other hand, it's also very nice. And then feel you really good when you save a life.
Thank you.
You have any questions?
I was wondering, in your personal journey, did you have a I made it moment, or any moment where you felt like
When I
you were
passed step one,
successful?
It was very painful for me to pass that steps, and then when I passed that, I feel really good, really good.
Because I think for us, as medical students, even scoring well on a quiz or doing good on an exam makes you feel empowered. But for someone like you who's so much farther in their career compared to us, I was wondering what your personal experience was.
Yeah, the thing is, some things that you can do very easily because your education and then your skills can make it easier for you, but it can be very difficult for me. And some things which is very easier for me, and then it can be very difficult for you. It changes. The thing is, the mountain that changes from one person to the other person. The mountain can be step 1 or 2 for me, or it's very easy. It's just a little bit, you know, bulging for you. You know, it's not a big deal for you. But the thing is that changes, but the pattern of the solving the problem is it's the similar. I just wanted to say that. Thank you. Yeah.
Do you have any questions?
The thing is, you know, people may think that step 1 is easy, but after 15, 16 years, you know that you're not going to use gastrointestinal anatomy, or you need to work on that while you are lab manager, and then you have a family and you have to deal with your son and these kinds of stuff. And after 6 or 8 hours working in the lab, and you go back and then study on that. It was difficult for me, but you know, if I could turn back to while I was in medical school, you know, I could pass that, and then I wouldn't have that mountain in front of me. That may be another mountain, but maybe money for you is a mountain, but you know, if you work, you know, you can fix it, or you can solve that. Yeah.
Sir, thank you for your presentation. First, my question is, I'm a first year of medical student. So I would like to learn what's your biggest advice for a first year of med student in this pathway? Like, what was the special thing that made them choose you inside a lot of good, skilled people?
Thank you. Nice question. The thing is, I want you to, you know, observe different fields, and then find what is best for you, and then what makes you more happy. And if you find that path, if you enjoy doing something, it's not going to be a work for you. It's going to be your hobby, or it's going to be a joy for you. And then you can very successful in that field. You know, if you observe that and then observe yourself, it's not that easy. You know, you don't know yourself. I don't know myself. You know, I learned along the way how I behave if I don't sleep 48 hours and then I have to do something. You know, I don't know. Maybe I quit. I didn't quit, but I might. You know, I learned myself along the way. I'm not telling that it's a supernatural thing. You know, it's personality. You know, it's different. It can be different. It can be good or bad. Find yourself which makes you happy, and then go that way. And then, but wherever you go, if you are doing medicine, if you are doing basic science, whatever, try to do your best. And it's very important for not only for yourself, but also for society, but also for our families. You know, because of that, I would like to share my experience with you. And then I want you to be better, much better. Thank you.
Let's take the last question, if anyone has. Or you may ask in Turkish if you want. Online question. Let's take the last question from here, then go continue with the.
I can speak Turkish if you want. A little bit.
This is a little bit a personal question, but so much. But like, do you say, I wish I could spend more time with my family or things like that? Because
the thing is, you know, it depends on where you're looking. I enjoyed my time. Not all the time. Life is like if you are achieving work, you know, joy comes with that. Okay, you know, for example, if you are in a very small village and then you never taste a chocolate. Okay, you just got some apples or something like that, but you never taste chocolate. And when you taste the chocolate, you need to go for that, right? You know, that's really good. And then I think, you know, saving life in surgery, it's like a chocolate for me. You know, when you have that, you need to be better to feel that feeling again. You need to do some sacrifice. You need to sacrifice, but it doesn't mean that it's going to be painful all the time. It also gives you some joy along the way. Not all the time. I showed you, the difficulties to prepare yourself for these. There were also very nice things about that. It's not like that. But the thing is, one thing can be good for one person, the other can be can be very, if you say that it's unnecessary, it's necessary good. It's if you know yourself, it's good to decide that way, and then you can stay away from that path. Surgery is not for all people. It's sometimes, other branches are very important. Every branch, every part of medicine is very important. The basic science is very important. The pharmacy is very important. Whatever you do, if you are serving to people, if you are doing a good job, it's going to give you a joy. But every part, you need to do sometimes, you need to sacrifice. You need to accept that.
Most of the surgeons you are not.
It's like chocolate, I mean,
don't choose it. They always say this to me.
The thing is, they may not like it, or they might not have, they were not lucky enough to enjoy their time over there. But as I mentioned, listen to yourself, observe yourself. Sometimes people do decisions, but they are not good for them. But they make a bad decision. That's a bad decision for that, unfortunately, for that surgeon that didn't enjoy the surgery or their field, and because of that they regret. But it doesn't mean everybody is like that. It's hard. It's very hard. Sometimes it's painful, but it's also very nice.
Thank you, Hocam, for your presentation.
My pleasure.
We will give you a plan. Career of the C.
Oh, thank you. Ben sizde mi dursun? Ben
Böyle. Tamamdır. Arkadaşlar beklerseniz bir toplu fotoğraf çekineceğiz. Bir de ben biraz kulüpten bahsedeceğim. Böyle katılmak isteyenler falan varsa.
Tamam. Thank you very much.
Şöyle gelirseniz hocam,
Tamam.
bir de herkese birlikte çekelim.
Tamam.
Size zahmet.
Tamam. Teşekkür ederim. Ben New York bir hastaneyle kontrat imzaladım. New York lisansını bekliyorum. O yüzden böyle bir fırsatım oldu. Bir özel hastaneyle imzaladım.